This webinar series is designed for physicians and birth workers, inviting and challenging physicians and staff to promote individual, interpersonal, institutional, and structural changes to make their institutions more equitable. This webinar will provide a platform for participants to reflect, react, and learn how to incorporate anti-racist practices into their clinical care, learn how to build trusting relationships with patients of color, and create spaces for these patients to feel heard, understood, valued, and safe. Today's topic is humanizing maternal mortality. I would first like to set the stage by reviewing the current state of maternal health here in the United States. Maternal mortality is a public health crisis in America. According to the CDC, each year, almost 1,000 women die from pregnancy or pregnancy-related complications, and up to 80% of these deaths were preventable. The US has the highest maternal mortality rate among other industrialized countries, and maternal mortality rates have increased since the COVID pandemic, whereas they are decreasing in other countries. Black women die at a rate 3 to 4 times that of white women, and these disparities persist even when controlled for socioeconomic status, education level, and comorbid medical conditions. In 2017, Lieutenant Dr. Shalon Irving, a fierce champion of health equity for women of color, was one of those deaths. Up until that time, the purposeful narrative was that these mothers were uneducated, unemployed, uninsured, and living in poverty as an explanation for the disparate rates. Dr. Shalon defied the conventional wisdom of who is falling victim to maternal deaths in this country. Here today are the mother and best friend of Dr. Shalon Irving to talk about Shalon and her legacy. Wanda, Bianca, hello, please introduce yourselves.
Hello, Dr. Gibson, and thank you for having us here today. My name, as you said, is Wanda Irving, and I humbly refer to myself always as forever the mother of Dr. Shalon Irving. I'm co-founder of the Dr. Shalon's Maternal Action Project we call DSMAP. It's a nonprofit founded to honor the work that my daughter was doing so vigilantly. As an organization, we focus on systemic change through policy and advocacy. We provide evidence-informed programs aimed at improving health outcomes for women, most specifically for Black women. And I always introduce myself in settings like this as forever the mother of Dr. Shalon Irving. I do that for 2 primary reasons. One, it's who I am now. I'm no longer the person I was before my daughter's death. And that reminder centers me and keeps my purpose in the forefront of my mind. It gives me the daily motivation I need to keep her death from being in vain.
Thank you, Wanda.
Thank you so much.
Yeah.
And thank you so much, Dr. Ericka Gibson. I'm excited to be here today alongside who I also call Mom, Wanda Irving. I am Bianca Pryor, so I'm more affectionately the best friend of Dr. Shalon Irving, and I'm also the co-founder of Dr. Shalon's Maternal Action Project along with Wanda. I also helped co-found and launch our Believe Her app that we developed back in 2021. When I'm not up to things in my 5 to 9, during my 9 to 5, I am a media researcher and insight specialist at a large media and entertainment company. And I'm also a mother, so you'll hear more about that, as I move through the line of questioning this afternoon. So excited to be here. Thank you.
Thank you both for being here. And Wanda, thank you for, really describing why, you consider yourself forever the mother of Dr. Shalon Irving, your daughter. Can you tell us more about your daughter?
My daughter was an amazing woman. She was a phenomenal woman. Let me clarify that. Professionally, she was a scholar. She had dual PhDs, 2 masters, a published author, a distinguished alumni of Johns Hopkins School of Public Health, lieutenant commander in the U.S. Public Health Service. She was a well-respected epidemiologist at the Centers for Disease Control. But on the personal side, she was funny, loving, adventurous, very, very humble, and a fiercely loyal friend. And she had a way of brightening up your day just by being in her presence. As a daughter, she was the measuring stick for a remarkable daughter. With her, family always came first, and mommy was first on that list. We talked every day, every single day. It didn't matter if we were in the same room, the same city, the same state, or the same country. She always made it a point to check in daily with her mommy to see how I was doing. She was just incredible.
Wow, she certainly sounds incredible. Bianca, tell us about your friend.
Yes. Shalon and I, we met at Purdue University back in 2002. And when we initially met, there was a curiosity about one another. We're like, who's that? And I saw that she'd gone to Hampton and I went to Virginia Union. So there was this geographical connection as well. And we immediately after that, we started going to Black Graduate Association events and we hit it off. And I knew that we were forever stuck at the hip. And just like Mom Wanda said, she was hilarious. Shalon was funny. We were going through an intense graduate school process, right? Learning how to be scholars, learning how to do research. We were at an R1 university. There were a lot of just day-to-day intensities that having her as a best friend and support allowed me and her to move through it. And I'd say as life carried on outside of Purdue, when we both graduated with our respective degrees, we moved through life's ages and stages. But what I want to say here for this part is that we were also caregiving for terminally ill siblings. And I think that also brought us together in a very different way. Because in your 20s and 30s, most in our peer set were not moving through that. They were getting engaged, buying homes, getting married, having children. And that just didn't happen for us, during those years. We were focused on our family and charting our own path. So we had each other to lean on in that respect. And it just continued to deepen our friendship. And Shalon really became like a sister to me, more than just a friend or best friend, but she was my soul sister. And everything that Wanda said, she was brilliant, hilarious, and more than that, she was resilient. And she always saw life with half glass full, always, no matter what. So it was a absolute joy to be pregnant together. She was 10 weeks ahead of me. So, she had a little bit more insight on some of those pregnancy milestones than I did. And, I was able to just, all right, girl, tell me what's next. What should I expect? What questions should I ask at my appointment? And that's a peek. Hopefully it's a helpful peek into our sisterhood and friendship.
Yeah, absolutely. Thank you both for sharing your stories and really giving us a rich picture of who Shalon was and who she was, to both of you. Wanda, I'd like to know just what Shalon's experience was during pregnancy and what were some of the her experiences that led up to her unfortunate death.
Shalon always wanted to be a mother. She was 4 years old when her baby brother was born, and he became her baby. She'd feed him, change his diapers, love on him all day long. And that nurturing spirit never left her. When she unexpectedly became pregnant at 35, she was overjoyed. She did everything right. She ate right. She exercised. She went to her appointments, everything that was required of an expectant mother. And she had a textbook delivery, but the euphoria of having that child was short-lived. Within a few days, she began to experience complications and her blood pressure began rising. She went to her high-risk doctors time and time again, no fewer than 5 to 7 times over a 2-week period with her concerns. And even though she presented with troubling signs of distress, like high blood pressure, swollen limbs, trouble voiding, and headaches, each and every time she was sent home with nothing, no treatments. She was told time and time again, don't worry, give it time, you just had a baby. And that went on for each of her visits. I accompanied her on her last visit. She had gained 9 pounds in that 7 days prior to that visit. One leg was visibly swollen, twice the size of the other one. She had a headache. She had high blood pressure, high enough that the nurse took it twice because she thought the reading was wrong at first. Shalon pleaded with her to please send in a doctor. I need to talk with a doctor. There is something terribly wrong. The nurse went out, came back maybe 20, 30 minutes later without the doctor, only to tell her, well, the doctor's too busy. He can't come in right now, but he did give you this prescription for high blood pressure. Take it and give us a call in 3 or 4 days if you're not feeling better. My daughter went home and collapsed that evening and never regained consciousness after that. She was taken off of life support 4 days later.
I'm sorry, I know it must be really painful to relive that experience. And it certainly sounds like she, came in, multiple times and, you're really describing, expressing those concerns and just, having her experience that her concerns and symptoms really weren't taken seriously. Was that your interpretation of how things went postpartum?
Absolutely not taken seriously, and not validated. She was not respected for the professional that she was, number one, and the fact that she knew health. She didn't have an MD, but she was a lieutenant commander in the public health service. She had an MPH. She had been dealing with all of these issues. Prior to coming to the CDC, she worked with what was Head Start, and she knew health, and she knew her body, and she absolutely knew her body than any doctor in that room. And she was telling them that there is something wrong. Please check, see. The blood pressure was screaming, there's something wrong here. No one paid any attention to that. They disregarded it, dismissed her, and sent her home.
Certainly. The next question is for both of you. With the experiences that Shalon shared with you throughout her prenatal course, do you feel that she had a good relationship with her clinicians? Did she ever share, any other experiences, interacting with the healthcare system that may have sort of played a part in her postpartum course?
Well, I'll start off and then let Bianca talk, because I know they had such a close relationship that she probably shared a lot more with Bianca than she did with me, because she didn't want to worry me. But from what I saw, she had a good relationship with her OB-GYN. She was a LGBTQ person, and they seemed to be able to talk and be able to relate in ways that she didn't with the older white gentlemen who were her specialists. And she mentioned several times that she just wasn't being heard. And Shalon could command an audience. She really, people were enthralled when she got up to do a speech or whatever, but these men paid no attention to her.
Yeah, just to build off what Wanda said, I think knowing Shalon so intimately like I did, we were sisters. Just to paint the picture, we texted multiple times a day, like at a minimum, at least 5 times a day, and she was my person. And so I knew, so exactly to Wanda's point, she had a close relationship with her OB-GYN. She did feel heard by that individual. I think where things started to break down, as Wanda said, were with other physicians and providers outside of that scope. I will say that OB-GYN would often say, you know what, let's get you to a high risk, or let's try this out. And so I think that there was a level of experimentation and their patient-physician relationship that was very helpful to Shalon. And Shalon, being a researcher, being curious by nature, that was very important to her in that setup, in that relationship. But I think, when the breakdown started to happen, that experimentation went away, right? Nobody wanted to invest the extra minutes or look through her charts to see that maybe there was a pattern there, or maybe that they were in the wrong. So I'd say some other things that, perhaps Shalon was withholding not to worry mom is things as simple as breastfeeding. That was complicated for her. It was difficult. And we talked as best friends, as birthing people, like what that experience was like for her. She was going through sleeplessness, just the sheer discomfort, not being able to even put on yoga pants because of the post edema and her legs were so swollen. Just very real examples like that, all the way to even more tactical administrative things like birth certificates for our children. And what is that process going to look like? And weighing some very complicated things and scenarios around that. So all in the spirit of not worrying her mom. But that's what best friends are for, to hold that space for her. And we did exactly that. And then there was certainly space that we built out in our friendship to imagine, the more hopeful, bigger picture. Are they going to go to Montessori school? Should we move abroad to Amsterdam and raise our babies together and bike around Amsterdam? So there were visions, and then there was like day-to-day things that the two of us really spent a lot of time texting, talking, chatting on the phone about.
And both of you alluded to this in your answers, but I'm interested in your thoughts about why you think Shalon's education didn't protect her. As I mentioned in the introduction, I think the misconception around the disparities in maternal outcomes is that, it's because Black women are more likely to be of lower socioeconomic status or have less education or less support. And again, that was not Shalon's case. So what are some of your thoughts around why the education didn't protect? And are there other social determinants of health that, impacted outcome?
Do you want to start?
Sure. I mean, I think what comes to mind is, one thing is you can't, especially postpartum, and having been there myself, is you are just physiologically and physically exhausted birthing a human. And I think that regardless of your level of education, there's no protection there. You're still a human that has birth, and it's hard. And sometimes your wherewithal and your ability to advocate for yourself diminishes, and you're exhausted and you're tired. So you couple that with someone when you're standing across someone with a different power dynamic, perhaps with racist proclivities, then that's just a bad combination right there waiting to happen. And so regardless that she had a PhD, it can happen. It can happen. You could be in an interaction patient-physician and still not be able to speak up for yourself, or then they're coming down on you and you don't know what is that chain of command. Like, where do I go next? And I know for me, in my own experience, I did not know that there was such a thing as a patient safety officer and that I could have called on that, but that comes with a level of being able to navigate, medical industrial complexes and knowing that that's available to you. So hopefully that response is helpful, but I think it's very much just birthing a human coupled with who's on the other side of that.
And adding to what Bea said, it's interesting. I found a particular statistic that said that Black women with college degrees are 60% more likely to die than a white woman without a high school diploma. And that boggles my mind. Why is that? Um, it just goes to show you can't educate yourself out of maternal mortality. You can't. It doesn't matter what your bank account looks like, where you live, the fact that you're not in poverty or you're not whatever all the conventional wisdom had, I outlined for maternal mortality victims. It is something that I feel the only social determinant of health that affected Shalon as just like other Black women, is racism. And I think Bea brought it up. That is the only qualifier that I could see, because none of the other ones fit the scenario. And the fact that she came in there time and time again. It wasn't like she was begging for prescriptions or trying to get medication or anything like that. She's presenting with symptoms that are begging doctors to please take a look. And it didn't matter, it shouldn't have mattered, rather, what her education level was or her standing in the community. She was a woman of value, and she should have been treated with respect and treated for her symptoms. And that didn't happen. And the only reason I can see that didn't happen was because she was a single Black woman coming in there with a child trying to get help.
Wanda, I agree. I've definitely seen those same studies and statistics that, really boil down the increased risk, regardless of the socioeconomic status, education. And when you remove all of those, sort of confounding factors, you really are boiling it down to just race. And with that, with that background, I think that the racism can show up in different ways. And one of the ways can be implicit bias. And Bianca, do you think implicit bias, or how do you think implicit bias shows up in that physician-patient relationship? And what do you think its impacts are on maternal mortality?
Sure, yeah, I do. I do think that the implicit bias or racism creeps in. It does. And I think it creeps in as early as initial, OB-GYN visits. They're assessing how articulate is that birthing person, what's their occupation, and they have their standard rubric they're supposed to ask, but you also know there's another filter happening in their mind as well. And it's gauging, I think as a patient, we're bought to believe into the idea it's going to gauge how many visits you're supposed to have, if you need a referral to high risk, all of these different things for your birthing journey. So absolutely, I remember when I had a visit and I was about 20 to 22 weeks and I was in pain. I just wasn't feeling well, malaise, nausea, diarrhea, and I called my OB-GYN. And what the irony of this story is, I lived literally in the same building as the practice and told them, I do not feel well. And they said, we'll wait and see. And literally, I had to be rushed to the ER the following weekend. And it turns out my amniotic sac had perforated. So, then the ball moved from there, going to the maternal unit, transferred to antepartum just to stay pregnant. So, the fact that I had, the signs were there, advanced mother age, after Latina woman, all these things were there, but they didn't think to treat me, more delicately and with more care. And so I think absolutely. I think too, I have actually an opposite example. When I went to, it was a checkup around week 12 for the vital organs of my baby. And this was actually for me, a encouraging example where it wasn't implicit bias, but it was cultural competency. And my son was showing signs of being polydactyl. And the sonographer was holding back actually and hesitant, like, she was very worried. She's like, I have something to share, but I'm not sure how to share it. And it's interesting because I knew that on the father side of my child, they have polydactylism. So it wasn't a surprise to me. And, because it tends to be a Caribbean trait. So it didn't come to me as a surprise, but I think that's a great example of the sonographer explaining that to me and saying there's nothing to be worried about and that, this tends to be a trait. And so it's, again, just an opposite example of being culturally competent all the way down to the extreme, what, my best friend Shalon experienced, obstetric racism. So yeah, lots of examples, but it certainly creeps in the process.
Right. And maternal mortality, implicit bias, all of that, that's not a new phenomenon. This has been going on for decades. It's something that is ingrained in the foundation of America, in all our systems. And it shows up in the healthcare for sure. Look at J. Marion Sims and all of the operations that he did on slave women. Okay, maybe we did get some good medical treatments out of it, but the cost was a bit high. And what he has ingrained in that was the foundation for treating Black women without respect. And that's where a lot of this started. And it's still taught because some of the stereotypes are still very, very alive and well in medical school. There is a different physiological difference between Black women and white women. We're stronger. We have more, what is that? Ability to take pain. All of those kinds of things. I'm surprised that young doctors still believe some of that stuff. And that is what leads to a lot of these poor outcomes because they're operating with this implicit bias when they try to treat us. And it's not like everybody doesn't have a bias. We all have biases, but you've got to learn to put that aside and look at that as a person, as someone who has value. Look at her as if she were a member of your family. And that's what gets me. If they had looked at Shalon like, oh, this could be my sister, this could be my daughter, this could be my mother, what would I do? They certainly wouldn't have patted her on the head and sent her home. So that implicit bias has got to be separated from the kind of patient care that you provide to your patients.
Wanda, I agree, and thank you for bringing up those points, and especially, sort of laying out the foundation, with the example with Marion Sims of just the historical context, that sort of created this situation where, we have implicit bias that shows up, in all of these different ways. There was a study done with medical students at the University of Pennsylvania recently that really reiterates your points where the medical students, still there was a significant proportion of them that believed that there were racial differences in experiences of pain, skin thickness, et cetera. So, those are implicit bias that show up within that patient-physician relationship. And there's definitely a lot more conversation, I would say, on a positive note around implicit bias in needing to address implicit bias in order to, change the tide in maternal mortality and really sort of across the whole healthcare spectrum. I'm really interested in hearing from both you and Bianca. From a patient perspective, how do you think that health systems, how do you think that, as physicians, that we should address implicit bias?
Well, personally, for myself, I think there has to be some kind of an accountability measure built in to addressing implicit bias. There has to be a way that people are held accountable for how they treat patients. And whether that is the carrot or the stick, there must be something there that you're going to be judged on. and that you have to treat this patient with respectful care. That's how I would start off. And all of these trainings are good, but they don't go far enough. You know, getting a certificate, going for 5 or 6 hours, that's not enough. You know, I'll stop there because we have a new initiative that'll be coming out fairly soon around this kind of training. So we know that there needs to be something different.
For me, I go back to empathy and immersion. And even when I go and visit Wanda and Soleil and spend time in Atlanta with them, I'm reminded of how my best friend's mortality, like this ripple effect, you know, this aftermath that has happened, and how Wanda has to continue to go on, raise a 7-year-old little girl, and all those expectations to survive and thrive are still there and still exist. And I'm met with, that's hard. And if only physicians and nurses and even payers, if they had a sneak peek and could see into that, you know, what is really happening after mortality, they would be on it. They would be in this movement with us to solve for this crisis. And so it's seeing firsthand, you know, how do you go on and survive and put your life back together? I think it's enough to develop and create that empathy. Now, what I'm not saying is that it's enough to overcome racism, and that's a whole different conversation because that has levels to it, you know, structurally, individually, organizationally, so many levels to unpack there. But I think cultivating some empathy is a very strong start.
Agreed. And Wanda, back to your point about implicit bias training, I know that there are, you know, definitely different training modules available across, you know, healthcare systems and online. But I do also agree that it's a continued learning process. So it's definitely not a one and done, you know, type of thing. So as physicians who, you know, are lifelong learners, we definitely should incorporate, you know, elements of implicit bias training as part of our continued medical education. So thank you for, you know, for bringing up the training aspect. I want to ask really both of you, you know, what do you think is important for physicians to know or to do to improve communication with patients, and how might this impact maternal mortality?
Do you want to start?
Sure. Yeah. I think, you know, I think it's just evaluating their own verbal and nonverbal communication style for one. And I think it's creating, whether it has to be a checklist, a filter, whatever the thing is for you to audit yourself and figure out, where am I potentially creating breakdown? Where am I not asking key questions? You know, if someone profiles as a certain background, then that's your opportunity to probe, dig deeper, and ask further questions. Beyond is there a history of that? Or even, you know, what is like your level of understanding? Like, so when Shalon and I were pregnant, at the same time in 2016, she was far more informed, I will say, than I was about the birthing journey. So even a question like that is, where are you going to for your sources and your information? Because say they're following an influencer that's giving misinformation, you know? And so I think, you know, helping to modulate, like, what is that patient's own intake of information could be helpful information. So I think, you know, evaluating and auditing their own you know, dialogical practices is going to be really, really important.
And just to tag along with what Bea has said, understanding that there is a power dynamic. When you're sitting in front of a patient, that patient sees this white coat, they see this person that is in their minds, or maybe in their minds, so far ahead of them, and they have a problem, maybe even connecting. Understand that. Take the time to build that trust, that relationship. Make sure they understand that you are there to help. You're not there to judge or to, be God. You are there to help. That was your oath, is to never do any harm. And that's what people need to better understand when you are sitting in front of them. Take the time. Don't say, well, I have 5 minutes here. What do you need? Really talk to that patient and better understand where they're coming from. The empathy that Bianca brought up was very important. Put yourself in their shoes, or see your own daughter in their shoes, and better just understand that this is a difficult situation for them, and they may not know what some of the right questions are to ask, but you do. You can at least help them with the kind of information they need. I think it's really important also to understand cultural differences in the patients that you're treating. There was one study, I can't remember what it was, but um, the woman was in the room with a doctor, and she kept doing this. And so the doctor wanted to send her down for a psych evaluation because he couldn't understand, like, why is she hitting herself in the head? But what they found out was that this Black woman had braids and they were itching. So she was hitting herself in the head. Understand some of those cultural differences. Don't send her off to the funny farm because she's doing something that is natural for her. And that's where I think a lot of the breakdown comes. A lot of doctors have a particular plane that they see everything on. And we're not all up on that plane. Understand that there is a wide variety of patients, and they come from different points of view, from different cultures, from different backgrounds than you do. And try to be more empathetic, as B said.
One thing
Yes.
I would,
Oh, go ahead. I'm sorry, Bianca.
okay, the one thing I want to build on, because I think it's important from a tech standpoint too, is just that a lot of communication too is being held, the charts are being held in these automated portals and systems. And I think it's important for physicians to explain that, like, my main modality for communicating with you will be through this portal. Please make sure you follow up and check and look into it. There's going to be key information. Or if there's something alarming, I will call you, and be clear about, how you're using these automated systems, because I think that's another piece of this as well too. And it wasn't as prevalent, when Shalon and I were pregnant. It was still very much in-person visits and phone calls. But I think that's an important piece for both physician and patients to really get clear on, like, how is this going to work for me, and how are you going to talk to me through the system, or should I expect a phone call?
Yeah, really, really great points. I think about, the empathy and really recognizing the power dynamic in the relationship, and the technology piece, both from, where patients are getting their information, and that the whole can of worms with social media. But also when I think about communication, I'm thinking about the, one-on-one communication with the patient, but you bring up a really important point to consider, that communication now is also through the computer. And there are some elements that are lost in that communication. So understanding how that factors in, to that relationship and ability to, sort of understand someone through the computer, but laying the foundations for, how to access care, I think is just super important point. So thank you for bringing that up. I know you mentioned earlier, Bianca, about the Hear Her campaign. I know that is a resource for physicians. Are you involved with the Hear Her campaign? I just wanted to have both you and Wanda weigh in on, what resources physicians, have to just sort of assist them in this continued education and improvement.
Mhm. And so the Hear Her is the CDC's campaign, and we have the Believe Her app. So there's certainly a bit of wordplay there. And within the Believe Her app, we do have a whole suite of resources that you can go to, like birthing persons. I think it's a birthing person's Bill of Rights and like what you should know. And we are also endorsers and strong supporters of the Momnibus as well too, which is more at a policy level. But we have lots of information and resources where we've done all the groundwork to partner with lots of different on-the-ground organizations, doula ones, midwife ones, the CDC, and the list goes on, to pull their resources into ours so that there's a one-stop shop for information for sure. But we absolutely support the CDC's Hear Her campaign initiative and love what they're doing to bring star power into it and to really elevate it and to push the word out at a national level. And it's certainly data backed as well too, which you need.
And we do partner with the CDC Hear Her program from time to time. In fact, I'm speaking at one of their events in April. We've done a couple of campaigns in the past with them. But as Bianca said, we have the Believe Her app, which is a peer-to-peer support app for Black women to get the kind of information they need in a timely fashion, because emergencies don't have a 9 to 5. So we do offer digital technology like the Believe Her to do that. There are a lot of different apps out there. There are a lot of different resources, but I think people have to be careful in what they look for and what they decide to use to get information or to share information. So that's why we are very, I guess, very pro Believe Her app and Hear Her, because both are pretty well, I would say, vetted. Yeah.
Mm-hmm. Great. So two great resources that listeners of the webinar can provide to patients or just peruse and look for information for themselves. Bianca, how would you describe the legacy of Dr. Shalon Irving at this point? And how are you and Wanda continuing her legacy?
I mean, as we've just shared in this conversation, and I hope this conversation has like evoked, her spirit and who she was. But I mean, Shalon was really building legacy even prior to her mortality. Like she was already up to some amazing projects, working on some great work at the CDC. So she left her thumbprint on lots of different organizations, anywhere she worked, any interaction. But I'd say posthumously, like I think that, she's garnered so many awards and recognition, even at the CDC. Her story has made so many headlines and really big publications. But I think the biggest legacy, hands down, is her daughter, Soleil, who's 7 years old now, and she's every bit of her mom. And from my view, and having been Shalon's best friend for 15 years, I see it, the way she will raise an eyebrow. It's like, that's her mama. Soleil's brilliant. She's spunky. She's fun. She loves to ask questions. And I know she's destined to be, someone powerful and immense in this world. So that's, I would say, Shalon's biggest legacy, hands down.
I would have to agree. And she plans to be a doctor. So she oscillates back between being a vet and being a baby doctor. So we'll see how that turns out. But Shalon was, she was just a fierce champion of health equity. And there are so many times I either get an email or text from people who tell me that Shalon set their path in this field and how they are, in fact, moving forward and making changes because of who Shalon was and what she was doing in the field. So I see her work continuing in a lot of different people. And that kind of warms my heart. You know, I miss my daughter terribly, but she had a saying, a mantra: I see inequity wherever it exists. I'm not afraid to call it by name, and I work hard to eliminate it. I vow to create a better earth. And though she's not here with us, the work that she did, the life she led, the kind of example that she set is meeting that vow every day because people are picking up that torch.
Well, I can certainly agree with that. And both you and Bianca are doing the same. So, thank you both so much for, for your work in Shalon's name. What role can medical associations like the Medical Association of Atlanta play to better protect patients like Shalon?
When I think of the Medical Association of Atlanta, I'm brought to y'all's history since 1854. I mean, that's some tenure right there. And you have a very like a historical and a big meta point of view that you can bring, not just on Black maternal health, but I think beyond that and start to draw different connections. I think one of the advantages you all also have is that spirit of medical leadership. And I think medical leadership is really important, but I think that organized action, like being able to galvanize the greater Atlanta area to do something about it. So not just on the perch talking about all these great things, but moving the entire medical industrialized complex to do something about it. And just studying all the different bios of all the members, including yourself, Dr. Gibson, it's like, wow, like there is some real star power here that can be leveraged geographically, but also I think, at scale for sure. And I think what's also interesting is we know the greater Atlanta area is a maternal toxic area. So being able to dig deeper and hear and find and source those stories, other Shalons, in the area, to push at that national level, because we need the mommy bus and we need other programs to really push and make it past the house. So I think y'all have so much power and heft just in one organization alone, to really make that impact and make that change.
I think the only thing I can add to what Bianca has said is to perhaps maybe form relationships, collaborations, or partnerships with organizations that have that kind of lived experience knowledge and really take advantage of that information and that knowledge as you move forward.
Thank you. Those are really valuable suggestions. Do you guys have any last words before we close?
I'm thankful and have a lot of gratitude in my heart for being able to be a part of this webinar and be in conversation with you, Dr. Gibson, and all the listeners out there. Thank you very much for your medical leadership and continued advocacy and work towards solutions. So thank you. And I know together we're stronger to solve for this crisis.
And I would echo what she says and add that we all have a role to play, and don't shirk your responsibility. Everybody has a role.
Thank you. I want to deeply thank our guests, Wanda Irving and Bianca Pryor, co-founders of Dr. Shalon's Maternal Action Project. I would really thank you for sharing your daughter and your friend's story. And I'm confident that her legacy is going to continue to improve maternal health for all women, especially Black women who are disproportionately affected by maternal mortality. I'd also like to thank the Medical Association of Atlanta for hosting this webinar and really shining a light to the maternal health crisis.
Thank you.